Thank you, Dr. Bernal, for that informative lecture. We have our next two speakers will be presenting via video. So our next speaker is Dr. Jose Martin Paiso. Dr. Paiso is a trailblazer in spine surgery and is currently the head of spine at Asian Hospital and Makati Medical Center. He will be presenting iatrogenic spinal deformity. So please play Dr. Paiso's presentation.
Good morning. I would like to thank the PSS for allowing me to give this talk on iatrogenic spinal deformity. Iatrogenic spinal deformity is an abnormality in spinal alignment resulting from surgical and non-surgical treatment. The deformities may not necessarily lead to adverse results. The incidence of iatrogenic spinal deformity is between 15 to 75%. Occurrence depends on age of the patient, numbers of levels treated, location of a laminectomy if one was done, adjuvant treatment like radiation therapy and other pathologic factors. The biggest risk reported is in children undergoing laminectomy for interspinal tumor and then receiving postoperative irradiation. Incidence is close to 100%. We will focus on iatrogenic adult spinal deformity, also known as flat back. The condition was described in the 1970s by Moe and Denis when they observed in a subset of patients with idiopathic scoliosis undergoing fusion to the lumbar spine and sacrum with Harrington rod instrumentation. There is loss of lordosis and the center of gravity was thrown forward, and they coined it flat back syndrome. It has been proven that fixation to L4 or L5 to S and even the sacrum, that distraction rods reduce lumbar lordosis to 21 degrees and 16 degrees respectively. Preservation of lumbar lordosis is possible though by ending the Harrington rod instrumentation at T12. Another cause with the use of more modern transpedicular fixation is the failure to maintain or enhance lumbar lordosis. This was prevalent in the early 2000s where patients with degenerative lumbar stenosis underwent or were treated with decompression and posterolateral fusion without interbody devices. The goal focusing more on neurologic decompression than enhancement of lordosis. That's why the preoperative lordosis usually ends up the same after surgery. Pseudoarthrosis or failure of fusion can also result in iatrogenic spinal deformity, like this 55-year-old male who was a smoker who had a 3-level T-lift for back and leg pain. As you can see, a reasonable lordosis was achieved during surgery, but 12 months after, the patient had a recurrence of back pain and presented with pseudoarthrosis as shown on the X-ray as loosening of the screws, breakage of the implant, and measurable loss of lordosis. Intraoperative positioning has also been identified as a cause, especially with the use of the old Andrews frame, wherein the hips were flexed 90 degrees. With this setup, lordosis loss is 67%. The ubiquitous Wilson frame, where the hips are flexed 30 degrees, there is a resultant loss of lordosis of about 26%. While the more modern frames like the Allen table and Jackson table, which allow for hip extension, it is possible to preserve physiologic lordosis during surgery. Therefore, prevention of iatrogenic spinal deformity starts in the preoperative phase. Appropriate assessment of the patient's sagittal alignment is key, so pay very close attention to the upcoming speakers. Limiting caudal extent of the fusion, like favoring selective thoracic fusion for scoliosis when indicated, is also helpful. The use of segmental instrumentation and pedicle screws with avoidance of distraction in the lumbar spine can help minimize iatrogenic spinal deformity. And of course, optimal patient positioning during surgery is desirable. This may be achieved even if you have a Wilson frame. Just put pillows underneath the thigh of the patient to promote hip extension and lumbar lordosis. Iatrogenic spinal deformity is disabling. It has been shown with patients with flat back deformity that there is an increase in lordosis and the remaining mobile segments with decrease in thoracic kyphosis. The sagittal vertical axis is offset more than 50 millimeters, and patients with this condition develop paraspinal muscle fatigue easily. Pelvic retroversion, hip extension, and knee flexion come out as compensatory mechanisms, and over time, back pain increases due to adjacent segment degeneration. Conservative management is very basic and consists of bracing, the use of NSAIDs, and physical therapy for trunk stabilization with measures to improve back and hip extension. Although it may help initially, it is really of little lasting benefit. The undertaking is still worthwhile to help patients decide on surgery and improve preoperative fitness. With this approach, expect that 58% of patients fail and move on to revision surgery. The general goal of surgery for iatrogenic deformity is to restore physiologic lordosis and sagittal balance with the SVA intersecting at the posterior sacrum so that when the patient stands, there is no knee flexion or hip hyperextension. At the same time, you have to treat the malunion or malfusion that is present. There is no algorithm, but a stepwise strategy suggested is to identify the deformity drivers like the presence of a pseudoarthrosis and locate the kyphosis apex. Set the alignment target by selecting the level where to perform the osteotomy for optimal correction, usually from L2 and below. And determine the deformity flexibility using extension radiographs before surgery to decide if the goals can be met with the posterior-only approach or combined approach. I will not go into the details of surgical management and techniques, but highlight two osteotomies commonly employed. An extension osteotomy can be performed, which is basically a bilateral facetectomy with spinous process undercutting, followed by compression through pedicle screws. Because the bony contact is minimal, pseudoarthrosis rate is higher, and there is a potential for great vessel injury due to anterior column distraction. Because of these reasons, anterior release and grafting is oftentimes employed with this technique. A more extensive resection to include the pedicle and the cancellation of the vertebral body, also known as pedicle subtraction osteotomy, may offer even greater correction. The union rate is high because the closing wedge is bone on bone, but one must take care to ensure that the combined exiting roots are not compressed during the reduction. The two osteotomies can provide up 20 to 35 degrees of correction in a single vertebral level. Spinal balance is achievable for these patients with flat back syndrome. Kim reported the results in 2015 in their series of 49 patients, 10 of whom had iatrogenic spinal deformity using posterior-anterior posterior approach. They performed ALIF in at least 2 to 4 levels and utilized sacropelvic fixation. In their series, 11 of the 49 patients required additional osteotomies during the second posterior surgery. Here is one of the lucky patients showing excellent balance after surgery. The goals were achieved in his series, uh, or spinal balance was achieved in 35 to 49 out of the 49 patients, or 71.4%. SVA was brought down to less than 5 cm in 31 of the 49 patients, 63%. And more importantly, the ODI, pre-op ODI scores improved significantly at 2 years. There was no pseudoarthrosis reported. However, there were revision surgeries on 4 patients, and he did not report any medical complication in his series. The more recent publication by Louis in 2022 is the largest retrospective cohort study to date. It reports 41 patients who underwent Harrington rod instrumentation with a mean follow-up of 27 months. In this series, majority of the patients had posterior osteotomy only, while 14 had anterior-posterior surgery. Because of the high risk for pseudoarthrosis, RHBMP2 was employed in 73%. The mean blood loss in this group is 2 liters, and the mean OR time was 13 hours and 22 minutes. Patients stayed in the hospital for at least an average of 8 days. Here's an example of one of their patients showing excellent sagittal balance after the treatment. However, they go on to report that the complication rate is 61%. The most common complication encountered was transient neurological deficits in 9 patients, or 22%. What is interesting is that 8 patients had revision surgery, or 19%. Of the 8 patients, 7 had only posterior, were treated with only the posterior approach. There was 1 patient who had revision surgery and had to be revised again. In spite of these complications, at 12 months, the sagittal alignment was maintained, and the SVA was less than 50 millimeters in most patients. The mean ODI also decreased at 12 months follow-up. So in summary, iatrogenic spinal deformity will continue to challenge us and optimizing the index surgery with current knowledge is the best way to lessen their occurrence. Detailed preoperative assessment, limiting fusion when possible, limiting fusion levels when possible, meticulous fusion techniques to avoid pseudoarthrosis, and proper patient positioning to preserve physiologic lordosis is key. Non-operative management may work for patients with mild cases of iatrogenic spinal deformity, and surgery is helpful for those who are more disabled, but the details should clearly be disclosed for the informed consent. I would like to thank my 10 mentors for helping me become a spine surgeon. Maraming salamat po. Thank you for listening.